Examination is looking at ligament instability in the knee. Initially we'll start at looking at the medial collateral ligament. With valgus stressing of the knee, that usually examines the medial collateral ligament. The medial collateral ligament is the primary restraint to valgus stress to the knee. The medial collateral ligament is the most commonly injured ligament in hockey players. This is an injury that even at its most severest form will usually be treated non-operatively since it heals extremely well with appropriate type of immobilization. When testing the medial collateral ligament, though, not only do we test the knee in full extension, but also we do it at about 30 degrees of knee flexion. The reason for this is that the posterior medial capsule is very taut in full extension, and this comes into play here. In full extension, we are not only examining the MCL, the medial collateral ligament, but we're also examining the posterior medial capsule, and also part of the cruciate ligaments act as tertiary restraints to this ligament. So for us to isolate the medial collateral ligament, we have to flex the knee about 20 to 30 degrees and then apply a valgus force to see if there's been any injury to the medial collateral ligament. In regards to the lateral collateral ligament, the testing occurs by trying to apply a varus force across the knee. And again, the lateral collateral ligament is not injured very frequently. Most likely 90–95% of the time you will be seeing a medial collateral ligament before you would see a lateral collateral ligament type injury. The next part of the examination, as far as ligament stability, we'll be looking at the anterior cruciate ligament. The anterior cruciate ligament is one of the most commonly injured ligament in basketball players and football players, and usually it is a season-ending type of an injury. Although most people know the anterior drawer examination, that's with the knee flexed at 90 degrees and the foot stabilized, the examiner places his hands across the proximal aspect of the tibia, and you have to ask the patient to really relax and then to see if there's any anterior shifting of the tibia onto the femur. So again, although this is the most common exam, this is not the best and most sensitive exam to look at ACL injury. The best examination at looking at anterior cruciate ligament injury is the Lachman's examination. That's with the knee flexed to about 20 to 30 degrees, that isolates completely the anterior cruciate ligament, and with a force that is applied on the tibia in an anterior fashion, you would be able to see if there is any anterior subluxation of the tibia onto the femur.
Now it's recording.
Examination is looking at the posterior cruciate ligament. Well, the posterior cruciate ligament, the posterior drawer is the best examination at looking if the tibia subluxes posteriorly onto the femur in an abnormal fashion. We see this fairly frequently in car accidents when the knee hits the dashboard and the tibia is driven posteriorly and ripping the posterior cruciate ligament. For most people who are examining knees, we'll probably see 60 to 70 anterior cruciate ligaments injuries before we'll see one posterior cruciate ligament injury. With any of these examinations, when examining the ligaments, it is extremely important to remind the patient to relax. You always have to remind them to relax all of these tendons in the posterior aspect of the thigh in order to do these exams. The next portion of the exam is looking at the pivot shift phenomenon that is usually seen when there's an anterior cruciate ligament tear. The way this is performed is by grabbing the patient's leg and allowing the femur to droop posteriorly relative to the tibia because of gravity. So if a patient had an ACL tear, complete tear, at this point their tibia would be subluxed anteriorly because their femur relative to that is sitting posteriorly. And as we apply a valgus force and flex the knee, there would be an abnormal shifting of the knee, which Dave has a little bit of a trace of that at this point. Okay. Dave, let's examine the other knee. Okay. This is Dave's contralateral knee, the uninjured knee, and we'll be doing a pivot shift on this leg. Again, extending the leg, placing a valgus force onto the knee, and then flexing the knee from that position. And you can see that this knee does not have the trace pivot shift that he has on the contralateral side. The next portion of the examination is looking for meniscal tears. Again, initially we had talked about palpating the area posterior to the cruciate ligaments along the joint line to see if there's any pain there. However, the best examination to look at meniscal tears is by performing a McMurray's examination, by hyperflexing the knee and with internal rotation and valgus stress looking at lateral meniscal tear, and external rotation and varus stress looking at medial meniscal tears. What you need to know is that when we perform this examination, we're not only looking for pain in the area where the patient is complaining of, but also we're trying to palpate an audible or palpable click. If there's something that clicks or pops inside the joint as we're doing this examination, then McMurray's testing is positive. The other part of the examination is looking at the patellar kind of pain. We've discussed already palpating the facets, but also gently pushing posteriorly onto the patella, causing a grind test and having crepitus sensation. This could relate to some articular cartilage damage behind the patella. Just because you can feel crepitus in the knee, though, that does not automatically mean that the patient will require any type of surgical intervention. Thank you.